are going to start the session. I request Dr. Renu Madam to call upon the first presenter.
Good morning, everyone. Before we begin, I would just say that every presenter is allowed only 5 minutes, and this should be followed by 1 minute of question and answer. Presenter cannot be changed. We won't allow that. So the person leaves the competition. So if I think that is it. And with that, we would start today's session. Is the first presenter here, Dr. Shilpi. Dr. Shilpi Narnavare. Is she here? Okay. So, Dr. Vartika Yadav, please come. So, Dr. Vartika Yadav is here and she is presenting a presentation on posterior vitreous detachment in myopia, and this is a cross-sectional study.
Good morning, everyone present here. Good morning, judges. I am presenting my paper on the topic Understanding Posterior Vitreous Detachment, and I am Dr. Vartika Yadav from Rohilkhand Medical College and Hospital, Bareilly, and I am giving my paper on the topic Understanding Posterior Vitreous Detachment and Degenerative Changes in Myopic Eyes. Starting with my paper, posterior vitreous detachment occurs when the vitreous humor separates from the retina. This condition is more prevalent in myopic eyes due to the structural changes in the vitreous body. The vitreous humor, which normally maintains contact with the retina, becomes liquefied and collapses over time. As myopia progresses, the elongated shape of the eye places mechanical stress on the vitreous, leading to its detachment from the retina. Myopia and its impact on the vitreoretinal interface. Myopia, especially high myopia, is associated with axial elongation, which causes a stretching of the retina and vitreous. This elongation leads to earlier onset of vitreous liquefaction, vitreoretinal interface changes, and increased risk of PVD. In high myopia, degenerative changes such as lattice degeneration, macular holes, and retinal tears are common complications. PVD can lead to retinal tears or detachment in these eyes, which can result in severe vision loss if not detected early. Risk factors and pathophysiology of PVD in myopia. Axial lengthening and aging are significant risk factors for PVD in myopic patients. Increased axial length stretches the vitreous body, creating mechanical stress leading to earlier detachment. Age-related vitreous degeneration occurs more rapidly in myopic eyes, with patients often experiencing PVD earlier than emetropic eyes. The risk of complications, including retinal detachment, is higher in myopic eyes, making earlier ophthalmic evaluation essential. Epidemiology and clinical importance of PVD in myopia. The prevalence of PVD increases with age and axial length. In the general population, PVD often occurs in patients over 50, but in high myopia, PVD can occur as early as in the 30s or 40s. Patients with axial lengths over 26 mm are particularly at risk. Clinical detection of early PVD is crucial, as untreated PVD can lead to complications such as retinal tears, vitreomacular traction, or retinal detachment. The aim of my study was to study prevalence, clinical profile, and association of different grades of posterior vitreous detachment in myopia. Objectives: to determine prevalence of posterior vitreous detachment in myopia in different age groups, to analyze degenerative vitreoretinal changes in patients of myopia, to examine the association of choroidal neovascular membrane in myopia, to study occurrence of retinal breaks and retinal detachment. Inclusion criteria: patients above 20 years of age with complaint of painless diminution of distant vision with myopia, patients with axial length more than 24 mm, and patients giving informed consent. Exclusion criteria: patients with curvatural, lenticular, or index myopia, patients with hereditary vitreoretinal dystrophies, patients with vitreoretinal disease, patients who had undergone vitrectomy, and patients who had history of blunt trauma. Materials and method: this study was done on a sample of 164 patients who had come to the ophthalmology OPD above 20 years of age, satisfying both inclusion and exclusion criteria. A detailed history was taken, giving due emphasis to the complaints, onset, duration, and history of wearing spectacles, and family history for suspected refractive errors. A preliminary examination.
About this is not working.
Okay. A preliminary examination of uncorrected and best corrected visual acuity for distance was conducted. Refraction was conducted meticulously to evaluate the true refractive status of each eye. Slit lamp examination was performed to evaluate the anterior segment of the eye. Keratometry was conducted to measure the curvature of the cornea. Intraocular pressure was measured to monitor any changes in eye pressure. A-scan biometry was performed to assess the axial length of the eye. Fundus examination and imaging were done to observe the posterior segment of the eye. B-scan ultrasonography was utilized to evaluate the posterior vitreous in retina. OCT was used to provide detailed imaging of the retinal layers. Patients were divided into two groups based on their myopic refractive error after the pinhole test. Patient A, patients with a myopic refractive error between 0 to 6 diopters, and group B, patients with a myopic refractive error greater than 6 diopters. Results: prevalence of PVD. Overall PVD prevalence was 38%. In high myopia it was around 51%. In moderate myopia it was around 35%. In mild myopia it was around 20%. Degenerative changes in retina. Lattice degeneration was seen. High myopia around 35%. In lattice degeneration in 35% cases were seen. In moderate myopia 15% cases were seen. Macular holes were observed in 7% cases of high myopia. Correlation between PVD and axial length. Mean axial length in PVD patients was seen to be 26.7 mm. Mean axial length in non-PVD patients was found to be 25.2 mm. Statistical significance P less than 0.05 mm, less than 0.05. Coming on to the discussion, the study shows a high prevalence of PVD in myopic patients, particularly those with high myopia. Degenerative retinal changes were also more common in these patients. Axial length and age. Axial length and age are significant risk factors for PVD. Regular eye exams and OCT are significant for early detection and management of PVD and associated conditions. OCT has proven to be an essential tool for diagnosing PVD and detecting subtle degenerative changes in the retina that may not be visible on standard examination. OCT can provide high-resolution images of the vitreoretinal interface, allowing for the detection of partial or complete PVD, epiretinal membranes, and other early-stage abnormalities. Conclusion: proactive management. Patients with high myopia should be counseled on the importance of regular follow-ups, even in the absence of symptoms, due to the asymptomatic nature of early-stage PVD. Proactive management, including the use of OCT, can help prevent complications and maintain visual health in the long term. Thank you.
Yes, very good presentation. But you have not grouped patient into ages. Do you think that the patient or 20-year-old patient will have retinal detachment because of PVD?
No,
Because
sir.
myopic changes of a 20-year-old boy and a 60-year or a 50-year man, when PVD will be different.
Yes.
So you have started from 20 years to 60 years, you know.
Yes,
So
sir.
it is all progressive. The degenerative changes are progressive according to the age. A young boy will not have PVD, or he will have.
Sir, sir, in older ages, PVD.
How many
will-
cases? What is the percentage of PVD in young age?
Sir, less common in younger age group. Rare in younger.
If in a
age group.
patient complete PVD has occurred and there is a hole, do you think round hole, flat hole? Do you think it will cause detachment? Peripheral hole, round hole, flat hole, no fluid, and there is complete PVD.
Yes.
You are trying to correlate between the macular myopic complications with PVD or a cross-sectional study, isn't it?
Yes, sir.
Okay, thank you. Any other question?
Next. Next is Dr. Malvika Sharma. Topic is Eye of the Storm, a rare diagnosis of ocular tuberculosis. Dr. Malvika. She's not there? Is Dr. Nancy here? Dr. Raja Narayan, Dr. Sania, Dr. Swati, Dr. Shivani, nobody is there. Dr. Shriya, Dr. Priksha, Dr. Priksha. So she'll be presenting her paper on unraveling the enigma of ocular sarcoidosis. Please stick to time.
Good morning, everyone. So today, my topic. Good morning, everyone. So today I am going to present on unraveling the enigma of ocular sarcoidosis. So in the first case, a 45-year-old female presented to us with the chief complaint of floaters in the right eye since 1 year. Her vision in both the eyes was 6/9 with the pinhole. In both the eyes there were vessels, in the right eye there were more as compared to the left eye. Opto's images shows vitritis, vitreous membranes, snowballs, candle wax drippings which were more in the right eye as compared to the left eye. This is the OCT image of both the eyes. Skin lesion was present just below the eyelid noted. Investigations were done and she is a known case of pulmonary sarcoidosis. Mantoux came to be negative. Serum A's were on the higher level, ESR raised, and the rest tests for the uveitis were within normal limit. FNAC from skin lesions confirmed cutaneous sarcoidosis. So the diagnosis of definite ocular sarcoidosis was made. Treatment, she is on oral and the topical steroids. Over a period of 8 months, her skin lesion healed and pulmonary symptoms also improved, but still she has recurrent vitritis as clearly indicated in the picture. In the second case, a 30-year-old male presented to us with the chief complaint of floaters in both the eyes. In both the eyes with the pinhole, the vision was 6/6. In both the eyes, there was +2 vessels, but in the left eye, there was old capes also present. diagnosed elsewhere as a viral parotitis, showing clearly the parotid gland enlargement. At presentation, patient has in both the eyes disc edema and the candle wax strippings in both the eyes, as clearly indicated in the optos and the OCT image. Investigation were done. Serum ACE on the higher level took no induration even after 72 hours. Quantiferon TB gold test negative. Chest CT showed significant findings. Diagnosis of the presumed ocular sarcoidosis was made and Heifetz-Waldenström syndrome. Treatment on the oral and the topical steroids. As clearly indicated in the picture, over a period of the 4 months, posterior uveitis completely resolved along with the resolution of the parotitis. In the third case, a 40-year-old male presented with the gradual painless diminution of vision in the left eye for past 2 weeks. Vision in the right eye was 6/6, left eye it was 6/12 part. Right eye posterior segment shows the subtle subretinal yellowish lesion over the IT arcade, and in the left eye it was along the posterior pole along with the subretinal fluid. These are the FFA and the ICGA findings with the correlating subretinal mass. On the B scan, thickening at the posterior pole with the high surface reflectivity and the intent variable to hypoechoic signal measuring this much amount present, so the DDO following were made. Investigation were done, serum ACE were on the borderline only, and the rest other tests for the uveitis came out to be negative, showed no induration even after 72 hours. Chest CT showed only subcentimetric side mediastinal lymph nodes. So the diagnosis of query sarcoid granuloma in a case of presumed ocular sarcoidosis was made. Treatment on the oral steroids. Over a period of 4 weeks after treatment, there was complete resolution of all the subretinal mass. In the fourth case, a 35-year-old male presented to us with a blurring of vision in the left eye since 25 days. His vision in the right eye was 6/12 with the pinhole and the left eye 6/24 with the pinhole. Fundus right eye clearly shows normal, and the left eye there is a large optic disc granuloma which is reaching up to the disc and up to the posterior pole. OCT image in the left eye. FFA shows the late hot disk, that is staining of the disc, and the large hyperfluorescent mass which is reaching up to the disc and the posterior pole. Investigations were done, serum ACE were on the higher level, CT showed the significant findings, and the IGR came to be negative. So the diagnosis of presumed ocular sarcoidosis was made. Treatment on the oral and the topical steroids. Even after 30 days treatment, there was not complete resolution. So the discussion part. Sarcoidosis is basically a systemic inflammatory disease of unknown etiology characterized by the formation of the non-caseating granulomas. These are basically the features reaching from the eyelid up to the optic nerve in case of the ocular sarcoidosis. These are few of the images from the article. A shows the mutton fat K-piece, B shows the multichoroid granuloma, C perivenous sheathing with the hemorrhages, D large granuloma along the IT arcade, and E shows the peripheral chorioretinal lesions. These few are the disc. B shows the hot disc with the vasculitis. C shows the hypocyanosin spots and the ICGA. This is the sarcoidosis of skin. We have similar case, broad raised skin lesions or the plaques that can be smooth or rough and skin color red. These can also arise from the tattoos. This is the article basically differentiating the TB granuloma from the sarcoid granuloma. Top row shows the intense yellow lesion with the SRF and the large basically. The bottom rows is the sarcoid granuloma, which are usually small, dull yellow, rarely distinguishable from the retina. This is the feature OCT differentiating TB granuloma from the sarcoid. In the TB, there is a contact sign basically, RPE disruption and the outer retinal layer hyperreflectivity. Whereas in the sarcoid granuloma, these are small, outer retinal layer hyperreflectivity is not present and RPE is usually intact. The evaluation can be done with the international workshop criteria and can be divided into definite, presumed and the probable sarcoidosis. In the definite, we need the biopsy. In the presumed, we do not need the biopsy, but BHL on the CSCT. Probable, we only need the 2 intraocular signs. Treatment, basically corticosteroids mainstay, rest biological agents. The conclusion, important for ophthalmologists to be aware of ocular manifestation as they be the first sign can lead to severe complication. Thank you.
Thank you.
Thank you.
Very nice presentation indeed. You
Thank
showed
you.
some very remarkable cases. So, did you try to get an endobronchial biopsy in any of the patients so that you could have instead of a presumed, you could have a definite diagnosis?
No, ma'am. In all the cases were not possible. In the definite first case, we had the skin lesion, and from that biopsy came out to be positive. So it was cutaneous sarcoidosis also, pulmonary cutaneous as well as ocular sarcoidosis.
And in the other cases, at the time of the eye manifestation, did they have systemic findings as well? Because we know that ocular sarcoid can present
No, ma'am. Few
independent.
patients didn't have any pulmonary symptoms.
No other symptoms.
What was your clinical differential diagnosis when you saw the patient first before any investigation? Only on fundus examination and OCT. What was your first DD But, or the sarcoidosis came into mind your first. That was your first diagnosis?
No,
Or do
sir.
you had any DD in your mind? What other thing can happen?
Sir, when it comes to the granuloma, I have DD of the TB also as well as sarcoidosis also. When it comes to the
Any other thing which can happen?
Sir, that if any other finding correlating,
You
then it can
mean
be
diagnosis of ocular sarcoidosis presumed syndrome is straight diagnosis, clinically? I'm talking of
Yes, sir.
clinically.
Clinically,
When you see the fundus, is it only the diagnosis or there are some other differential diagnoses?
sir, there can be differential also.
What are these?
Autoimmune diseases, basically TB, sarcoidosis, and the syphilis, uveitis. So we usually do the VDRL, TPHA.
What about posterior scleritis alone due to some
If
other
there is
reason?
not an even in single patient, there was ocular pain. There was no ocular pain. So, and the disc was completely normal. Posterior circulosis, usually disc edema is present.
Thank you. Thank you very much. Nice
Welcome, sir.
presentation.
Thank you.
So the next speaker is Dr. Anurag Prakash. Dr. Tanu Chauhan, Dr. Megha Arora. Anyone here out of you all who's presenting? No?
Any presenter here?
Dr. Shrey. Okay.
Shri.
So Dr. Shrey's topic is exploring choroidal and retinal angioarchitecture in dengue patients with associated dengue retinopathy using OCTA and CVI.
Please come.
Good morning, everybody. So today I will be talking about the importance of choroidal vascular index and angiostructure when we see patients with dengue retinopathy. So, move me. So dengue is a very prevalent disease, especially seen in the tropical climates. So Singapore and India are the two major areas where we find dengue, and so we get cases associated with it, that is dengue retinopathy. So this was a prospective study in which 18 patients were included, and 32 eyes of the 18 patients with positive NS1 antigen for dengue fever, and the mean age of the patient was 37.8 years. And the most important thing was that their platelet count was quite reduced, and it was around 76,000 plus minus 25,000 per microliter at the 7th day, that is the Nadir. And the follow-up was done as at 1 week, 1 month, and at the 6-month interval. So the main clinical features which we found, that the best corrected visual acuity was better than 6/18 in 10 of the patients. Between 6/18 to 6/60 in 14 patients, and it was less than 6/60 in 8 patients. Posterior segment findings were retinal hemorrhages, cotton wool spots, grayish yellow foveal reflex, which can also be called as foveolitis, and 2 cases showed some vitreous cells. So OCT findings were conical foveal elevation, ISOS disruption, inner retinal hyperreflectivity, and inner retinal cystoid spaces were seen. On OCT angiography, we found flow deficit areas in superficial and deep capillary plexus. And in choroidal vascularity index, we found that it was decreased at the presentation in all the patients when we compared it to the normative data of 50 patients that we had. And it was persistent in few cases even after the recovery. So few of the cases, so here is the fundus which shows cotton wool spots along with the retinal hemorrhages. Right eye was affected more. So the similar OCT picture, you can see few cells also in the CME, and as you can see in the inset, there is a foveolitis which you can see on the side. This is the OCTA picture for the same patient, and as you can see, the dark blue areas, which are the flow void areas which we saw. There was, when we saw the patient on the follow-up, the patient started doing better, the hemorrhages were reduced, the cotton wool spots also went down. This is the same picture with fundus autofluorescence.
Carry on, carry on.
The important thing is, like, when we compared the patient on the Octa, we found this, that the eye, which was good, as you can see on the left side, the flow was around 51.7, while in the affected eye it was dropped to 47.3. One of the most important parameter that we saw was choroidal vascular index, and this was done by the binarization on ImageJ software. The ratio of the total choroidal area to the luminal area was calculated. So this is how this yellow marked area that you can see was the choroidal vascular index that we calculated. And this was the finding that we saw, that average CVI at the time of presentation was 67.23 in the affected eyes, while when we compared it to the normative data in the similar age group, so it ranged between 69 to 69.56 to 70.26. Patient with CME showed more decreased CVI, but which just had CME, they recovered better. While with the patient who had foveolitis and a picture with acute macular neuroretinopathy, they didn't recover better. They had some persistent visual problems that was approximately in 7 patients, and their choroidal vascular index was decreased even after the recovery at the 6th month. So CVI range also correlated with the flow deficit in the deep plexus in the OCT angiography. So the final conclusion that we came to was that dengue retinopathy should be seriously looked on, and especially a patient who suffers with dengue and complains of vision should be referred to an ophthalmologist. And Octa plays an important role in judging the outcome, because if we find flow deficit in the deep plexus is quite there, and if CVI is also affected, then the prognosis is guarded, and frequent follow-ups are warranted, and a guarded visual prognosis should be explained to the patient. Thank you.
So how does this help you to treat the patient? Did you treat your patient on the basis of these findings?
Ma'am, the treatment was basically based on, like, we started them on the topical steroid or oral steroid, and in one of the cases we even had to give the intravenous methylpred. So when we correlated it with the flow deficit areas on the OCT angio and the CVI, so this was we found it in the hindsight that if we would have treated the patient who had major flow deficit areas, and if we would have started the treatment with the heavy steroid dose, their recovery would have been better instead of just starting them on the topical steroids as we know been normally doing with the other patient. So this thing can help us to identify where we should be hammering the patient with a higher steroid dose in comparison to the patient where only the topical or minimal steroid can be started, and their recovery.
And the patients you said who had a persistent visual deficit with foveolitis,
Yes,
were these patients started on steroids? Because if they had been started, again, you have not, just to say that they had a persistent visual deficit, was that after high dose steroids?
Persistent visual deficit, when they came to us, few patients were at counting finger 3 meters. They recovered, but they recovered up to 6-9
and they've
visual
all given
acuity.
steroids early on. They were all given oral steroids.
Oral steroids were not started for all the patient. Initially only topical steroids were started, but after the first or second follow-up, when patient were not responding well, so we started them on the oral steroid for the recovery. But the major conclusion that we get is, like, if we compare the OCT angio and if we compare the CVI, and we found that if we find that the flow deficit is too much, so the steroid should be started at the first go instead of waiting for the patient to.
Did you compare these patients, those who were treated and those who were not treated? Was there any difference in their visual acuity?
Any control study?
So we compared it with the normative data of the people, the normal, the patients who were not suffering from dengue retinopathy, but we didn't compare it to anybody who was not treated, because all the patients who came to the hospital, they were treated for the same. But when we compared, we found that on OCTA and CVI, the flow which we found, there was a difference between the normative patients and patients who were suffering. So the flow deficit was there actually present in the patients who were suffering. So it was comparison was done with the normative data, but it was not done with the patients who were
like
not
control.
treated.
So any other study in your mind where there was a comparison done by some other person?
So there are studies
Treated
on
or
CVI.
untreated?
On dengue retinopathy, there is one paper by Agarwal et al. It was a case report which was reported. So they also mentioned that the patient, she was actually diagnosed by the ophthalmologist as to be a dengue patient, because she just came with a complaint of a viral fever for around last 5 or 6 days. Suddenly she had the complaints of diminution of vision. So they went with the NS1 antigen report and they found that she was suffering from dengue. And in that they have mentioned that she had the fibullitis kind of picture, the acute macular neuroretinopathy picture. And they also have compared the flow deficit areas in OCTA-A. The CVI was not mentioned by them, the choroidal vascular index, but OCT angio was seen, but it was a single case report which they mentioned that flow deficit areas were there. But in other diseases, CVI has been done by Dr. Rupesh et al. And they have done an extensive studies on choroidal vascular index in other studies.
Did you find any retinal necrosis in any case?
No,
Or
sir.
Retinal necrosis?
No,
In
sir.
any-
No, sir. No, sir.
Any macular change post recovery on OCT?
Yes, sir. The ellipsoid zone disruption was seen post recovery at the 6-month interval.
How many cases?
Sir, it was seen in 4 cases. So yes, sir. So they on the Snellen's chart, they were not doing that bad, but their visual acuity, the subjective vision which they had, they complained about that even at the 6 months.
Did you test contrast sensitivity post recovery patients?
No, sir. Sorry, sir. Contrast sensitivity was not done, sir.
Thank you.
And there were no cases of retinitis because post
Yes, sir. No, ma'am, that was not seen. But as in one of the paper, they have even mentioned about the developing of CNVM post dengue.
and none of these patients was diabetic because the findings were overlapping, the cortical spots and the hemorrhages.
No,
you said.
no, ma'am.
They were non-diabetic
no,
patients.
No, ma'am. None of the patient gave history of the diabetes. Thank you. Thank you.
Is there any other presenter here in this room?
She's there.
Malvika, okay.
The other presenter, please stand before you leave. I think it's another girl presenter.
She's Malvika, no? Third paper. Third.
Good morning, everyone. I'll be presenting the Eye of the Storm, a rare diagnosis of ocular tuberculosis. This isn't working. Excuse me. It's not working. Tuberculosis is a serious infectious disease that affects about 1/3 of the world population. Ocular tuberculosis is a rare but known complication of TB. It is re-emerging as a major challenge all over the world. This disease can involve any tissue of the eye and the orbit. Ocular involvement can occur through either direct entry or as an immunological reaction to the organism, which can enter the eye from both epithelial and the hematogenous route, the latter being the most common one. The occurrence is more common in immune-compromised individual. The commonest manifestation is in the uveal tract, which presents as posterior uveitis. Tuberculous uveitis represents a minority of uveitis cases with varying prevalence ranging from 2 to 4% to 12 to 25% in different areas of the world. Despite significant research over the past decades, the diagnosis of ocular TB is difficult to both ophthalmologists and physicians due to lack of gold standard criteria to diagnose ocular TB, as clinical signs and symptoms mimic other conditions as well. A definitive diagnosis of tuberculous uveitis is confirmed by specific investigations like acid fast smears, culture of mycobacteria, or the PCR-based assays of ocular fluids, that is the vitreous and the aqueous humor. However, the sensitivity and specificity of these tests is not fairly high, making definitive diagnosis difficult. I am presenting a case of 40-year-old immunocompetent male who was diagnosed as ocular tuberculosis. So this 40-year-old male patient walked into the IOPD. He was normotensive non-diabetic euthyroid with chief complaints of diminution of vision in both eyes for 1 month. The diminution of vision was insidious in onset, gradual, progressive and painless. There was no history of flashes of light associated or any floaters or seeing any wavy objects. The patient also had a history of history of fever for 2 weeks duration. The fever was high grade, sudden in onset, continuous, associated with chills and rigors, and it was not relieved with medication. The patient, in the past, he has had a history of sudden diminution of vision 4 months back when he was diagnosed as papillitis in left eye and was managed conservatively with systemic steroids elsewhere. There was no history of any ocular surgery or trauma in the past. Coming to the examination, the visual acuity in the right eye was 6/9, in the left eye was 6/60. Rest of the anterior segment examination was normal, except for the fundus in the left eye, in which the media was clear, but there were multiple ill-defined chorioretinal tubercles present along inferotemporal quadrant and also around the macula. So a battery of tests were ordered to diagnose the case. Lab parameters showed TLC of 18,000 per mm³ with ESR of 46 mm. His purified protein derivative skin testing was positive with an induration of 18 mm, and that's when we thought of going for 24-on gold test to confirm the diagnosis if it was tuberculosis. Also, at the same time, radiological assessment was done, which revealed posterior scleritis also in the left eye. After these clinical test and investigations, a diagnosis of primary ocular tuberculosis was made. The patient was started on high-dose oral steroids after consultation with the chest physician, and along with that, he was also started on anti-tubercular drugs with pyrazinamide, rifampicin, isoniazid, and ethambutol for 2 months as intensive phase, and followed by 4 months of isoniazid and rifampicin. And at 3 months follow-up, the patient showed significant improvement in left eye with a vision of 6/18 with well-defined chorioretinal patches with pigmentation along inferotemporal quadrant and macula. However, the right eye showed no improvement. It was initially 6/9 and later on also it was 6/9. I'm sorry for the bad pictures. This is the only quality I could manage. So this is 3 months post-treatment. This shows healing of the choroidal tubercles, and the pattern has coalesced to form the chorioretinal atrophy. Tuberculosis is a serious infectious disease primarily affecting the lungs. Ocular TB is a vision-threatening variant of TB. Ocular manifestations can vary from lid and adnexa, orbital cellulitis, dacryoadenitis, periocular lymphadenopathy to flectenules, iridocyclitis in the anterior segment. Posterior segment can be involved in the form of vitritis, pars planitis, chorioretinitis, choroiditis, and optic neuritis. Sometimes ocular TB can be the only manifestation of serious underlying systemic active tuberculosis. In certain cases, ocular TB helps physicians to make appropriate early diagnosis with the help of an ophthalmologist and to decide further treatment. Ocular TB is more difficult to diagnose than pulmonary disease. It often needs more sophisticated lab techniques like PCR and gold TB quantiferon tests. Concluding it, tuberculosis can present with variable clinical manifestations. Ocular TB is one of the varied manifestations of systemic TB. This case highlights the fact that a seemingly innocuous eye involvement could be associated with significant systemic tuberculosis and thus requires thorough investigation and timely prompt treatment. Early diagnosis and timely intervention helps in preventing the occurrence of vision-threatening complications in the case. These are the references that I have used.
Thank you, very nice presentation.
So you mentioned that the MRI showed posterior scleritis.
Yes, ma'am.
What were the findings on MRI? How did they diagnose posterior scleritis?
Ma'am, there was enhancement. First of all, they did a USG on which there was a T sign.
No, you did the USG?
No, ma'am. We got it done from the radiology.
Okay, you didn't mention that. So this patient had posterior scleritis or choroidal tuberculoma?
Ma'am, both of them.
Okay.
Ma'am, the patient had the fundus picture that I showed. I could not take the pre-op picture. There were choroidal tubercles that made me think of tuberculosis, and his Montrose was also positive. And at the same time, the patient was complaining of sudden diminution of vision in the left eye. That's why we went for MRI.
Okay.
Did you check for any immunocompromised status of the patient?
Yes, sir. We underwent all this. The patient underwent all the serology, and it was negative.
Negative.
Negative, sir.
Also, when did you see the patients? Because the ATT treatment that was given to the patient was not according to the new guidelines. Was this a very old presentation? Because now ethambutol is
Ma'am, the ATT was put by the chest physician.
Okay.
It was recommended by them.
So according to the present guidelines, now ethambutol is continued beyond 2 weeks. This patient was given this. These were the older guidelines.
Ma'am,
I was
I'll
wondering
see
if when you saw the patient.
to- I'll see.
So mainly it was a clinical diagnosis.
Yes, sir, it was a clinical diagnosis.
Do you think the recovery was because of anti-tubercle treatment, or it could have been alone with the steroids?
Sir,
You gave combination of
So because
steroid.
initially when the patient came, there were active tubercles.
Yeah.
So the patient
Is
should
there
have
any
been
amount of vitritis associated
So
with?
there was no vitritis.
No
The media was
vitritis.
clear.
It was in the choroid and retina only.
It was chorioretinitis.
So what was unusual? Could you just sum up like what is the unusual thing about this case? We see
Ma'am, the,
choroidal. What was?
The unusual thing was that ocular tuberculosis would have been missed if the patient was not referred to us by the chest physician, because he had this complaint 1 month back, but then he did not seek any treatment. For fever, he went to the chest physician, and then he told the chest physician that I have ocular problem also.
That's okay. You said a rare diagnosis of ocular tuberculosis. What was the rare presentation in this case? I'd
Ma'am,
like to know.
This is
Apart-
usual presentation.
This is the usual
in
choroidal
which we doubt
tuberculosis. Yeah, you've
tubercular
written a rare.
choroiditis.
So if you
But,
could.
I saw it for the first
No,
time.
you would
so it
have
was
a,
rare.
yeah, that's okay.
As
So
a
in your
clinical
mind, what do you
diagnosis,
think was the rare presentation? The tubercles or anything else?
Ma'am, the combination of posterior scleritis along with choroidal tubercles, along with PPD being positive, so that combination for me was
Oh, good. And quantiferon gold was done for these patients?
Ma'am,
Which,
that is, we have a different chest hospital associated with us. That is.
and that turned out to be positive?
That was positive.
Again, in this patients, you could have tried to, in conjunction with the chest physician, asked him to do an endobronchial biopsy, which could have then, given you a better diagnosis.
That was not done. ma'am.
For PCR test, you took fluid from the anterior chamber or from the vitreous tap?
So PCR in this patient was not done, sir.
Not done.
Not done. It wasn't done.
You are very sure about the diagnosis.
So we were sure based on the clinical and the investigations, based on the clinical diagnosis and the investigations. And the patient responded to the treatment also after 3 months, and he's better.
Okay.
He has regained his vision also. He's 6'18". When he came to us, he was 6/60. Now he's 6/18.
So I'm sure you went into literature. How many percentage of patients with pulmonary tuberculosis active would show choroidal tubercles?
Ma'am, I did read, but I cannot quote the
Well,
exact
how
percentage.
then
I
did
don't
you
want to
know
be
that
wrong.
this was a rare case? You would have gone and read up, right? That
Ma'am,
how
because,
many patients
this was
would
one
have.
extra pulmonary case where the patient had ocular tuberculosis.
Okay.
That percentage is 12 to 25% around the world.
Okay.
Yes, ma'am.
We are asking this question because in our time, when we used to diagnose these cases, tuberculosis used to be the first diagnosis. You have to exclude tuberculosis, and ATT was a must in all cases of choroiditis initially.
ATT
But
was
later on, as the investigations further, they grew up, and the people realized that it is not tuberculosis unless proved otherwise. So gradually ATT was. Am I right? In our time.
So even now for
How
us,
many people give?
even now choroidal
Many people give
tubercle
choroid,
and,
yeah.
it's
Even
fairly common actually.
even in disseminated disseminated choroiditis is an indication for ATT or recurrence. If there is recurrence, so empirically you can give ATT, but it was all empirical, not definitive. So definite tubercular granuloma to diagnose is very difficult, and biopsy is all disastrous. Thank you very much.
Thank you.
Please sign your attendance here. So there is one more presenter. She had also come late. Nancy, right? Please come.
Dr. Nancy will be speaking on the etiological analysis of vitreous hemorrhage at a tertiary care center in North India.
Shall I start? Good morning. So I'll be presenting my free paper on this topic. Vitreous hemorrhage is the presence of extravasated blood within the space lined by internal limiting membrane of the retina posteriorly, non-pigmented epithelium of the ciliary body laterally, lens zonular fibers, and posterior lens capsule anteriorly. The incidence of vitreous hemorrhage is 7 cases per 1 lakh population. Vitreous hemorrhage is a common cause of sudden painless loss of vision, which usually present with sudden appearance of floaters, smoke signals, perception of red or black shadows, and cobwebs. It is important to determine the underlying etiology of vitreous hemorrhage, as the treatment and visual prognosis depend on the underlying cause. Timely management of vitreous hemorrhage can prevent sight-threatening complications. Our aim was to study the etiology of vitreous hemorrhage in patients attending tertiary care center to find the most common systemic association of vitreous hemorrhage. It was a hospital-based study, a cross-sectional study conducted in tertiary care center in North India after taking IEC clearance. Duration was 2 years. 80 patients were enrolled in a study after taking informed consent. Only those who gave consent were included in the study. After taking a detailed history, ocular examination was done in systemic way in every patient, and best corrected visual acuity, pupil slit line biomicroscopy, IOP were done. Detailed fundus examination of both eyes was done, and USG B scan was done for posterior segment evaluation in hazy media. All data collected were entered into computer software and analyzed accordingly. Laboratory investigations included blood pressure, blood sugar, including HbA1c, CBC, lipid profile, Montauk's test, coagulation profile, ESR, ECG, chest X-ray, CT scan, echocardiography were done wherever needed. The results of a study were, in a study, 70% were males, 30% were females. Bilateral involvement was done in 20%. Mean age of patients was 46.6%, ranging from 2 months to 70 years. Most common presenting complaint was sudden loss of vision in 52% of our patients. The presenting visual acuity 6/18 to 6/6 were present in 17 patients, 6/60 to 3/60 in 23 patients, and most of the patients were having their visual acuity between 3/60 to PL positive. Now this pie chart shows that 38% patient had PDR as the etiology, followed by trauma, and in case of PDR patients, most of the patients were type 2 diabetes mellitus, and in case of trauma, most of the cases were closed globe injuries. Now among the systemic association, most of the patient had diabetes, followed by diabetes and hypertension in 13%. In discussion, most of the cases, males were common, as followed by Lean, JC et al., Fogart et al., and Sharma et al. And this may be due to the more outdoor activities by the male patients, and unilateral involvement was more in Spring et al. And Raghuvanshi et al., as in line with these studies, and majority of the patient presented with visual acuity with less than 3/60, and these studies were in line with Maninder et al. And Fogart et al. The results of a study were variable, some similarities and some differences with a study. In a study, diabetes mellitus was the most common systemic association, which was in line with Desai et al. And Fogart et al. In a study, PDR was found to be the most common etiology of vitreous hemorrhage, as in line with Fogart et al., Desai et al., Wong et al. Also reported PDR to be the most common cause of vitreous hemorrhage, in contrary to Maninder et al., which show that BRVO in their study, BRVO was the most common cause. In a study, most of cases in PDR group had type 1 diabetes mellitus, which was in line with Dana et al.
Please finish.
In a study, majority of the patients had findings suggestive of vitreous hemorrhage. You can see in this B scan picture, the membrane echoes suggestive of vitreous hemorrhage. Also, among the rare cases was the case of a shaken baby syndrome with a subhyaloid hemorrhage. We had one case, and we had one more case of advanced ROP with a vitreous hemorrhage. Now, common etiology is for vitreous hemorrhage was PDR in our case, and adequate laboratory investigations are needed to correlate systemic associations. These are my references. Thank you.
You did not tell us about the duration for which this vitreous hemorrhage was present.
Actually, sir, we don't have the posterior segment in our hospital. So when we find such cases of vitreous hemorrhage or anything, we refer such patients. So as soon as they came to us, So most of the cases were referred. So for the duration they were present, it also varied among the patients. Some said that we had this loss of vision and we didn't report to the doctor. Some were coming after 3 months, some were immediately coming. That was
Did you find any case with a PVD, hemorrhagic PVD, and did you examine the
Sir, PVD,
periphery
yes.
of these cases wherever it was possible?
Yes, sir,
Because,
PVD was there.
Harshokia is also a common cause of vitreous hemorrhage.
So, but in
especially
our
elderly.
case, PDR followed by trauma was there. Yes, sure, there were cases of PVD also, but we didn't find much cases that were not on the higher side.
You have completely excluded the young age group. In young age also vitreous hemorrhage occurs.
Yes, so there
Vasculitis?
are vasculitis. Yes, sir, I have mentioned, but in our
BRVO
study,
can be because of anything. Vasculitis.
sir, there were other causes also, but
Yeah.
they were in minority in my study. PDR followed
As,
by trauma, then in
Dr.
few
Sharma
cases
told
were,
you that in the RD cases also you have, in acute PVD you have,
of course,
even
sir,
in
there
the
were
Valsalva
cases.
maneuver you can have vitreous hemorrhage.
Of course, sir.
So
Of course, there
you
were
are
cases.
only restricted to diabetic retinopathy
Sir,
or hypertensive retinopathy, because BRVO, what did you find the cause for BRVO? If it is vasculitis, it will recur.
yes,
It
sir.
has to be treated.
Yes, sir, there were cases, but I am saying that they were in minority. I have mentioned they were 1%, 4%.
Okay.
But most of them, the most common cause which I have found in my study was PDR followed by trauma. Less common causes included, of course, they included CRVO, BRVO, vasculitis, but there were few cases which were reported.
What was the treatment modality?
So, in which cases?
Vitreous hemorrhage, if it is not resolved?
Sir, as I already said that we used to refer such cases. My study was up to diagnosing the etiologist. Thank you.
Thank you very much.
Yeah, just a minute, it would have been worthwhile if you had classified these into the different age groups, you know?
Yeah.
The etiological, I mean, just
Below 20,
mentioning
20
the
to 40,
etiology and
40 to 60.
Noted,
percentage.
ma'am, noted.
Yeah.
You would have correlated it with the age group, that would have made it more worthwhile.
Thank you, ma'am.
And in one of your slides, you said that type 1 diabetes was the most common. And then while you were speaking, you said that most of the patients had type 2. And one of
Maybe.
your slides said type 1.
Ma'am, that
So
would be a
just
speaking error, but it was type 1. For
type
sure.
1.
Type 1 was more common.
Okay.
Yes.
Type 1 patients,
Yes.
okay. Type
Yes.
1 with vitreous hemorrhage, you saw so many
Yes.
of them. Okay.
Any anti-VEGF were given for vitreous hemorrhage?
No, she referred.
No
they
treatment
referred-
was given.
They referred
Treatment
all
was
the
given.
patients.
You referred all the cases.
Yes, sir, we did.
Thank you.
Also, you did not mention the type of trauma. You know, even that would have helped, made it more complete. So close to.
Any
Please sign here. Before we start, I would just like to find out how many presenters are still here. Is Dr. Raj Narayan here? I know. He's not here. Is Sania here?
Shilpi is not here.
Is Swati Mahajan here? Okay. Is Shivani here? Then Anurag Prakash, you're there. Tanu Chauhan and Meghna. What? Okay, the one who's present, please. Is Sania here? Please come in person.
She's Sania, no? Sania here.
Good morning everyone. I'm going to present about clinical characteristics of tubercular choroiditis patients presenting at a tertiary care center of Uttarakhand. Myself Sanjay Priyanka Kapu. My first co-author is Dr. Ajay Agarwal. My second co-author is Dr. Ramanus Samanta. The aim is to study the clinical characteristics of tubercular choroiditis patients presenting at a tertiary care center over 1 year. The secondary objective of this study was to compare the mean score of online COTS, Collaborative Ocular Tuberculosis Study Calculator, among different subtypes of tubercular choroiditis patients. The method in this was actually a hospital-based prospective study conducted at a tertiary care center at Uttarakhand over 1 year. in August 2023 to July 2024. Treatment-naive tubercular choroiditis patients of age greater than or equal to 18 years were included in the study. The tubercular choroiditis were actually defined according to COTS guidelines, collaborative ocular tuberculosis study, and was classified further into serpiginous like choroiditis SLC, multifocal choroiditis MFC, focal choroiditis FC, and tuberculoma. All patients underwent routine laboratory investigations like CBC, KFT, LFT. Along with them, TST, tuberculin skin test, interferon gamma release assay IGRA, chest imaging like chest X-ray or CECT, and other investigations as felt necessary were done. Online COTS calculator was used to calculate median score ranging from 1 to 5. Choroiditis patients with non-tubercular etiology were excluded. Patients with incomplete laboratory investigations were also excluded. Were diagnosed with tubercular choroiditis with male preponderance. Among 14 patients, 6 patients were of SLC, which is 42%, and 5 patients had MFC, which is of 35%, and 3 patients had tuberculoma. And TST positivity rate was 100% across all the 3 subtypes of SLC, MFC, and tuberculoma, while IGRA positivity rate was 100% in SLC, 60% in MFC, 66.6% in tuberculoma. The chest imaging revealed evidence of active or old infection in 66% of SLC and tuberculoma patients and 80% in MFC patients. The mean COTS calculator score was 5 in both SLC and tuberculoma group of patients and 4.5 in MFC group. All 14 patients with tubercular choroiditis received ATT, anti-tubercular treatment with systemic steroids. These are the pictures of SLC patient before ATT and after ATT, MFC patients and tuberculoma patients. Like we said, among 6 patients of SLC, all the 6 patients were positive for TST, all the 6 patients were positive for IGRA, and 2 patients showed old lesions on chest X-ray, 2 patients showed active lesions, and 2 patients shows normal chest X-ray. Thus, the median COT score was 5. In MFC, 5 patients were diagnosed with TST positive and 3 patients IGRA positive. 3 had old lesions and 1 had active lesions over chest X-ray, 1 with normal chest X-ray with a mean COT score of 4.5. In tuberculoma patients, among 3, all the 3 are TST positive, IGRA of 2 are positive, and chest X-ray active lesions are found in 2 patients and 1 patient is having normal chest X-ray and median score is of 5. Like we are having mostly SLC diagnosed patients, after that MFC with 5 and tuberculoma of 3. And we have diagnosed this criteria based on the COTS guidelines.
Please summarize.
According to COTS guidelines, we have taken only Montus, IGRAs and radiological tests like CCT and chest X-ray without any confirmed test of histopathology and PCR test to diagnose tubercular uveitis. On this COTS guidelines, this is the COTS calculator where we generally present with patient name, details and all, along with the clinical phenotype, endemicity of the patient and TST, IGRA, chest X-ray scans, which we came to know that the median score is 5, which represents very high probability for most experts to consider ATT treatment. Thus, we concluded that SLC is the most common type in our study cohort and TST was universally positive among TC, IGRA and all, and COT score was highest in SLC and tuberculoma group and all the 14 patients were received ATT and systemic corticosteroids.
Thank you very much.
So, how did you diagnose SLC? Like, what is the differentiating features that you kept in mind to diagnose a serpiginous-like choroiditis from serpiginous choroiditis?
Ma'am, serpiginous-like choroiditis will be having lesions, starting with small lesions and it will expand as a serpiginous patient with active part over.
No, just tell me the differentiating, like how did you, when you saw the patient clinically, how would you know this is serpiginous-like and not serpiginous? Because in serpiginous it has a tubercular etiology and serpiginous doesn't. So what are the differentiating factors? How did you classify them into SLC? Just the 2-3 points that you would think of. No, you don't know about that.
You have excluded all non-tubercular cases. What was the criteria for the tubercular choroiditis? Did you know beforehand that this patient is having tuberculosis?
No, sir. After coming, we will see the lesions and we will prescribe.
So once you are seeing patient in outdoor and you are diagnosed a case of choroiditis, at that time you will exclude or you will examine all the cases, then you exclude the cases of non-tubercular cases. I mean just asking how do we label that this case is a tubercular choroiditis and that case is a non-tubercular choroiditis? How will you differentiate? Then only you can include or exclude from your study, no? Bataiye.
We will first send for investigation, sir. And investigations, if it is Montus positive or Grass positive, along with chest X-ray findings, we will label him under tubercular or non-tubercular. If he is under tubercular, then we will differentiate him to SLC and MFC.
These all tests can be positive or Montus is a very non-conclusive test.
Yes.
Even you test your Montus, it will be positive.
Yes.
Right?
Yes, sir.
And all these tests are also found in allergy to tubercular
Yes.
protein or the type 4,
Yes, sir.
you know,
Yes, sir.
type 4 hypersensitivity.
Yes.
So how will you differentiate whether it is a tubercular or a type 4 type of reaction?
Actually, sir, we are following COTS guidelines. According to COTS guidelines, it is mentioned in the definition that it is of tubercular origin. If it is like positive for any radiological test like IGRA or TST, along with radiological tests like chest X-ray and CECT, without any PCR histopathological findings.
Okay, thank you very much.
All the patients had CECT done here, all these patients?
Chest X-ray we have done primarily, ma'am. If it is like
So, all the patients had a CECT in your series?
not all the cases, ma'am. If chest X-ray findings we are having any doubt, then we are proceeding for CECT.
Oh.
Did you check for the ethambutol toxicity during your treatment and your
Yes, sir. We
Post-op.
are checking for ethambutol
what kind of
toxicity
test?
also.
What test did you do to exclude whether the patient is developing neuritis because of the ethambutol toxicity?
Actually, we are seeing posterior fundus
Only
findings.
vision or something else?
Yes, sir. Vision and fundus findings only.
And?
Edema and
Field test? No.
field test also.
Thank you. Next.
Thank you.
Good morning everyone. The topic for my paper presentation is plasma homocysteine level in type 2 diabetic patients with and without diabetic retinopathy. So diabetic retinopathy is a major concern for healthcare system throughout the world as it is becoming the most common cause of blindness among adults. Increased homocysteine level being vascular toxic increases oxidative stress which leads to endothelial dysfunction, injury, platelet activation and thrombus formation. Increased homocysteine level in relation to diabetic retinopathy has gained special consideration in recent years, suggesting a strong association between them. There is also acceleration of cell injury at the level of retinal capillaries by these homocysteine, which may lead to development of diabetic retinopathy, as quoted by Zhu et al. In 2014. Homocysteine also induces the death of retinal ganglion cells in vitro, which is suggested by Murray et al. In 2001, and in vivo, as suggested by Ganapathy et al. 2009, by dysregulating mitochondrial dynamics. There is a direct effect of excess homocysteine, which causes disruption of blood-retinal barrier, which further causes retinal ischemia and neovascularization. The aims and objectives of my study was to determine plasma homocysteine level in diabetics versus non-diabetics, and to find the association of plasma homocysteine level with diabetic retinopathy. Material and methods. This was a case-controlled hospital-based and observational study. The study included 50 patients of type 2 diabetes, which were the cases, 50 non-diabetics, which were the controls. The place of the study was IOPD of Upgraded Department of Ophthalmology, GMC Jammu, duration being 8 months from November 2023 to June 2024. The history included age of the patient, year of diagnosis, age of onset, duration of diabetes mellitus, family history, smoking, alcohol intake, hypertension, and other associated illnesses, and history of drug intake, if any. The examination included visual acuity for distance vision, both corrected and best corrected, intraocular pressure by non-contact tonometry, slit lamp examination for anterior segment evaluation, slit lamp biomicroscopy with 90D lens, and fundus examination using direct and indirect ophthalmoscope with 20D lens. The participants were categorized as patients with diabetes mellitus that had no retinopathy fundus, that is non-diabetic retinopathy fundus. The second were the patients with diabetic mellitus with retinopathy fundus, that is having NPDR, PDR, or diabetic macular edema and CSME, and the further was classified into healthy controls. So homocystinemia, hyperhomocystinemia is classified as moderate range as 15 to 30, intermediate between 30 to 100, and severe more than 100, normal being 5 to 15. The inclusion criteria for cases include patients with type 2 diabetes, age more than 40, and willingness to participate in the study. Inclusion criteria for controls included non-diabetic subjects more than 40, people attending hospital for other causes, and willingness to participate in the study, and also healthy controls. The exclusion criteria included type 1 diabetes, alcoholics, drug intake mainly methotrexate, fibric acid derivatives, phenytoin and carbamazepine, pregnant women, megaloblastic anemia, and ocular conditions that may interfere with fundus examination. Also any fundus pathology other than diabetic retinopathy. The statistical analysis was carried out by SPSS software for Windows version 25, and comparison of the data was done by chi-square and unpaired sample t-test. All the tests were done at 5% level, and p-value less than 0.05 was considered as statistically significant. So the results, the diabetic mellitus patients, cases being 50, 35 had diabetic retinopathy and 15 non-diabetic retinopathy. The mean age of the patients was diabetic retinopathy was 63.1 plus minus 7.7 years, and that without diabetic retinopathy was 56.5 plus minus 7.6. It was higher in diabetic retinopathy group. The mean level of plasma homocysteine cases was 15.81 plus minus 6.45, and that of controls was 9.02 plus minus 1.18 micromole per liter. Difference was found to be statistically significant. This shows the comparison of hyperhomocystinemia in cases and control. As we can see, amongst 50 cases of type 2 diabetes, there were 22 patients that had hyperhomocystinemia, and none amongst the control had hyperhomocystinemia. This is the association of homocysteine with diabetic retinopathy. We can see that among 50 cases of diabetes, 35 had diabetic retinopathy, and among diabetic retinopathy, 19 had hyperhomocystinemia. This table shows the association of plasma homocysteine with fundus findings. As we can see that hyperhomocystinemia was seen in 3 non-diabetic retinopathy fundus patients, 10 in non-proliferative diabetic retinopathy patients, 6 in proliferative diabetic retinopathy patients, and 3 in CSME patients, and none in NPDR with CSME patients. So the conclusion is the results of a study reveal significantly higher prevalence of hyperhomocystinemia and higher level of mean plasma homocysteine in diabetic patients with PDR and NPDR as compared to control groups. These are my references. Thank you.
Thank you. In nutshell, you want to say that in proliferative diabetic retinopathy, level of homocysteines are high.
Yes.
Yes. So reducing the, or if you treat the homocysteine level, does it affect the course of treatment, or there is regression of diabetic retinopathy, or there is morbidity is decreased?
Sir, if we find out initially that there is an increase in homocysteine, we can interfere initially and we can help prevent the patient going into PDR.
That means you can postpone the diabetic retinopathy in which you are expecting.
Yes, sir. We can postpone the sequel of the patient. We can help him get the treatment.
So what are the signs in which you will determine that this patient is going to have proliferative diabetic retinopathy? Earliest sign?
Sir,
on angiography, fundus photography, whatever it is,
sir,
or OCT.
Sir, with the
That is what you mean, na? If you reduce the level of homocysteine, the course of the disease will be, proliferative retinopathy will decrease. Yes. This is what you mean, na?
Yes,
so how would you know that I should give homocysteine, or you give all homocysteine treatment to all diabetic retinopathy patients in which it is raised?
Sir, all diabetic retinopathy patients were given the test, and if there is homocysteine,
you give treatment.
Yes, sir. Yes, so we give folic acid supplementation, B6,
Okay.
B12. So and then we follow up the patient for fundus findings, and we see if there is improvement or if there is prolongation of.
Is there any study of two groups in which homocysteine level was decreased, or another group there was no treatment given for increased level of homocysteine, and course of diabetic retinopathy has affected? You have any idea about that?
So there was a study in which it was shown that folic acid supplementation treated hyperhomocysteinemia, and there was a decrease in the progression of the disease. There was a study shown, but still studies are being done to prove this.
So your study is only limited to higher level of homocysteine in diabetic retinopathy.
Yes, in diabetic.
And there you confirm it.
Yes, sir.
Okay.
So here you've compared it to the normal population and diabetics, or you've compared the levels between patients with proliferative disease and...
Ma'am, I have compared with both. That in controls, none of them had hyperhomocysteinemia, and within diabetic patients, in NPDR the homocysteine level was less as compared in PDR patients. That means the homocysteine level kept on increasing as the.
And patients without retinopathy did not have a high level.
No, hyperhomocysteinemia was not present in controls. It was less than 15, which was considered to be normal. 15 micromole per liter was considered to be.
No, I'm not talking of controls, just diabetic patients without retinopathy.
No, ma'am, in diabetic mellitus patients with NPDR, there was increase in hyperhomocysteinemia, but
Without retinopathy.
yes, ma'am, there was less
Okay.
as compared to PDR patients. That means homocysteine was not as high as shown in PDR patients.
Okay.
So it increased with the progression of diabetic
Got
retinopathy.
it. Okay, good.
Thank you.
Anybody else who?
Dr. Shivani, you are.
Anyone else in the hall who's due to present?
Please stop.
What is your name? Wow.
Yeah, please.
Good morning, everyone. I am presenting my paper on OCT macula and RNFL changes in high myopia and its correlation with fundus finding, axial length, and B scan. Aim of the study to determine the OCT macula, RNFL, B scan findings, and axial length in correlation with the fundus findings in the high myopia. Excuse me.
उनका टाइमर ठीक करो.
रिस्पॉन्ड नहीं कर रहा है.
इनकी टाइमिंग भी ठीक करवा दी. टाइम चलो बढ़ा देंगे, कोई बात नहीं.
With continuing
35
the material method, the study was mainly done in the KD Medical College in Mathura. Inclusion criteria: the age is between 6 years and 50 years. All patients with refractive error, more than -6 diameter, -6 diopter with the spherical equivalent, and patient visiting the hospital for the first time. The exclusion criteria includes any history of prior intraocular surgery, patient suffering from glaucoma, spherical equivalent less than -6 diopter, any history of corneal disease or having corneal pathology, any lenticular changes, any history of retinal diseases and having retinal diseases, any history or having retinal diseases, patient with the history of comorbidities, and signal strength of OCT less than 9/10 in either eye. The material method, the study duration was 4 months from March 2004 to June 2004 with a total of 98 eye. After taking history, the patients were dilated using 0.8 tropicamide with 5% phenylephrine. All patients underwent slit lamp examination before dilating the pupil. IOP recorded using NCT, wet retinoscopy after dilating the patient with PMT, and fundus examination using 90D lens, direct ophthalmoscopy and indirect ophthalmoscopy. The patient taken for the study underwent OCT macula, RNFL, OCT RNFL, A scan with emergent technique and B scan. The results include the sex distribution was mainly, a majority were males with 54% and female with 46%. Age distribution, the main age distribution was between 11 to 20 with the highest with 33%. Then family history was present in 14.5% and absent in 85.5%. Eye involved, the majority was bilateral with 98% and unilateral only in single case. The fundus finding, the fundus changes was present in 55% cases. The majority of fundus changes present are CR atrophy with 75%, tessellation with 76.6%, and temporal crescent with 63.3%. IOP, the majority was between 11 to 20 with 87%. Axial length was majority between less than 25 mm with 36.6 mm. Only more than 30 mm axial length was present in only in 11% cases. Refractive error, the majority of the refractive error was present between 6 to 12 diopter with 72%. Analysis of OCT of macula, normal altered OCT macula was present in only 10 eyes, that is 9.1%, with macular hole with traction only in one eye. Majority of as we can see in this slide, the mean macular thickness decreases with the increase of the refractive error. Then again the foveal volume and the analysis of macula. Here we can also see the decrease in the macular total volume as the refractive error increases from 6 to higher above more than 18 diopter. Then result on at the analysis of macula and fovea volume by OCT. The number of eye affected with the macular hole, highest were with active CNV with 37.5%. Fractional, the image shows the tractional maculopathy, active myopic CNV, and the lamellar macular hole. Then analysis of OCT with RNFL, the majority of the least eyes was present in the red zone, with the RPE thickness central and the average thickness was total eyes majority in 37%. In yellow zone with 13% and abnormal total was 50%. Then changes in the OCT RNFL in red zone. The majority were present in the 12 to 15 diopter with the average thickness was 10 in 100%. Then OCT or RNFL in yellow zone. Then B scan findings, normal B scan findings were present in 68.37%, with posterior staphyloма in only 6 cases, which consist of 3.6%. And coming on the discussion, the males were commonly affected, 54%. Highest incidence was between 11 to 30 years with 68%, and only 8 cases were present with the family history in myopia, and only 1 case has unilateral myopia, rest are bilateral. 55% eye shows the fundus changes like lattice, white without pressure or white with pressure, with posterior staphyloma, PVD and RD. Then average inner macular thickness in superior quadrant was 271.4 with plus minus 14.3, and according to that, the average macular thickness in the superior quadrant was 234.5 micrometer, and RFL thickness was found to, then coming on to the discussion, the RFL thickness was found to have the positive correlation with SE, which was statistically significant in the superior nasal and inferior quadrant, whereas in the temporal quadrant, RFL thickness does not show any statistical significance correlation with the SE. The highest correlation was found in the inferior quadrant with a coefficient of correlation of 0.58 with P is equal to 0, and RNFL thickness decreases with the decreases of myopia. Then RNFL thickness was observed to have the negative correlation with the axial length of the eyeball, which was statistically significant in the superior nasal and inferior quadrant. The negative correlation between RNFL thickness and the axial length of the eyeball in the temporal quadrant was not statistically significant. The highest negative correlation was found in the inferior quadrant with the coefficient of error, with the coefficient of correlation of 0.549. And coming on to discussion, the central macular thickness was 227.41. The parafoveal region was observed to be thicker than the perifoveal region. The nasal quadrant was observed to be thickest, followed by the superior and inferior quadrant and the temporal quadrant. The macular thickness was found to have the statistical significant positive correlation with the SE. The macular thickness was observed to have the statistically significant negative correlation with the axial length. And coming on to the last slide. In the study, the retinal thickness increases in the foveal region and decreases in the macular region. The retinal abnormalities in the macular area can be frequent finding in the eye with the degenerative myopia. OCT can explain the patient visual complaints in the highly myopic eye and may even show the abnormalities in the asymptomatic cases. It can also detect some undetectable abnormalities on routine ophthalmoscope examination in order to avoid the advanced retinal damage.
Thank you.
Here you said that you're going to clinically correlate this with the fundus findings, and I saw that the posterior staphyloma you detected only on B scan. You did not mention about the posterior staphyloma in your clinical findings. Why I'm saying is that the RNFL thickness would also correlate, would be much thinner in patients who have a posterior staphyloma. So did you analyze it in that way, like patients with posterior, because the retina would be more stretched in that area. So those patients would definitely have a thinner RNFL.
Yes, ma'am.
So did you show that correlation? It would have been a very interesting correlation.
Sorry, ma'am. Available in
Okay. So because in those, if you had said no, that's just simple without staphyloma and with staphyloma, that would have added to your study.
Primarily, what made you think about this study? What was the aim? Why did you study this?
So to establish the correlation between the axial length with the B-scan findings and OCT changes in RNFL and macular thickness.
Does it give any clinical significance that you should do in such cases, you should not do in such cases? What is the final outcome for the clinician? If some parameter is high, some parameter is low, so what precautions he has to take? Or how frequently he has to see those patients in which RNFL is decreasing, and how can you do it? The long follow-up is required, right? You have follow-up.
The long follow-up required with frequent
visits, yes.
With 6 months.
Follow-up is very short.
With 6 months frequent visits.
Also in your study, you did not mention the incidence of foveal hemorrhage or macular hemorrhage. The OCT you showed, where you said the patients had CNVM, they, sometimes on the OCT it's difficult to differentiate between in myopic CNVM and a hemorrhage. So did you do an angiography to confirm that it was a CNVM?
At that time, the fundus camera was not available.
Yeah, so because you just see that little elevation, many times it could just be a hemorrhage and many times it could be a CNVM. So you have to do angiography before you label it as a CNVM. So
thank you, it was a good effort. Thank you, it was a good effort.
Please sign here. There is one more presenter, right? Is there anybody else other than her waiting?
Dr. Meg.
Yes, sir, I had uploaded.
Just check.
I had already uploaded them.
She has something in
Sir, I have
लेफ्ट लगा दें, एक मिनट में हो जाएगा.
Good morning, everyone. The topic of my paper presentation is to evaluate the changes in refractive status intraocular pressure, and central macular thickness in pseudophakic patients after Nd:YAG laser capsulotomy. Posterior capsular opacification is also known as after cataract or secondary cataract, is the most common late complication of intraocular lens implantation after cataract surgery. It is caused due to migration, proliferation, and differentiation of lens epithelial cells. It can cause significant visual symptoms, particularly when involving central visual axis. The types of PCO are vacuolated or pearl type, fibrosis type, and sommering ring type. This is a picture showing posterior capsular opacification. The treatment of PCO is Nd:YAG laser capsulotomy, that is neodymium yttrium aluminium garnet laser capsulotomy. It is the creation of an opening in the posterior capsule. The complications following the procedure involves pitting of the IOL, intraocular pressure elevation, changes in the macular thickness, retinal tear or detachment, and cystoid macular edema. Aim of my study is to evaluate pre and post changes in refractive status, intraocular pressure, and central macular thickness in pseudophakic patients after Nd:YAG capsulotomy. Objective is to evaluate pre and post visual acuity using Snellen's chart, IOP using NCT, and central macular thickness using OCT after Nd:YAG capsulotomy in pseudophakic patients. Methodology: best corrected visual acuity was converted in decimals. PCO grading was done as per Selman and Lindstrom grading criteria. In all patients, number of spots with laser energy used were recorded. Post-YAG capsulotomy, the best corrected visual acuity, intraocular pressure, and central macular thickness were recorded on day 1, day 7, and 1 month follow-up. SPSS software was used to analyze the data considering unpaired t-test and one-way analysis of variance. My sample size was 60, including 23 males and 37 females, and duration of the study was 10 months. Inclusion criteria include all the pseudophakic patients above the age of 45 years attending ophthalmology OPD having PCO with visual symptoms and who were willing to give the written consent for this study will be included. And exclusion criteria includes patients who refused to participate in study or did not give written consent for the study, patients with posterior capsular opacification who are below 45 years of age or younger, patients with retinal abnormalities like macular pathologies, retinal detachment, or retinal tear, pseudophakic patients with corneal opacity, patients with posterior segment pathology like vitreous hemorrhage, diagnosed cases of glaucoma and on anti-glaucoma medications. YAG capsulotomy procedure. Nd:YAG capsulotomy was performed using Nd:YAG laser Apasami model 307. Patient's pupil dilatation was done with eye drop tropicamide plus 1%. Topical anesthetic Paracaine 0.5% was instilled twice. Abraham YAG capsulotomy contact lens was applied with HPMC viscoelastic. Application of head strap to maintain a forehead position following the adjustment of stool, table, chin rest, and footrest for optimal patient comfort. Provision of fixation target for fellow eye was done using the fixating light of YAG machine. YAG laser energy was kept minimum 1 millijoule with gradual progression. A cruciate opening was made beginning at 12 o'clock in the periphery, progressing towards 6 o'clock and then cut across 3 and 9 o'clock and any residual tags to avoid freely floating filaments. Selman and Lindstrom PCO grading is as follows. There are 4 grades of this grading system. Grade 1 includes no or slight PCO without reduced red reflex, also no pearls at all or pearls not to the IOL edge. Grade 2 is mild PCO reducing red reflex, etching pearls confined to the IOL edge. Grade 3 is moderate fibrosis or Elschnick pearls inside IOL edge but with a clear visual axis. And grade 4 is severe fibrosis or Elschnick pearls covering the visual axis and severely reducing the red reflex. Statistical analysis. Data collected for visual acuity, intraocular pressure, and macular thickness pre and post YAG capsulotomy will be tabulated and analyzed by using SSPS software. Mean values of all the parameters will be compared.
Please summarize, no?
Yes, ma'am. Ma'am, these are my result. Ma'am, total mean age is 59.43 with standard deviation of 5.36. Male mean age was 59.304 with standard deviation of 5.481. And female mean age is 59.514 with standard deviation of 5.368. So this is the data comparing the BCVA pre-op day 1, day 7 and day 30. There is gradual increase in, there is visual improvement from the pre-op day to day 30. This is the IOP. IOP, there is initial rise in IOP, following the decrease in IOP, and it remains almost same for day 1, day 7 and day 30. Central macular thickness for day 1, day 7 and day 30 is almost same. Mean value of energy used during each YAG capsulotomy is 1.81 joules. Conclusion, in pseudophakic patients after YAG capsulotomy, BCVA improves significantly without any significant increase in IOP or CMT. PCO grades and total laser energy used were significantly correlated to each other. However, they don't affect BCVA, IOP or CMT after YAG capsulotomy. Thank you.
Thank you, but you said you wanted to measure the CMT after and before the YAG capsulotomy.
Sorry, sir.
The
CMT, central macular thickness.
That was one of the aims of your study.
IOP,
Sir,
vision and
vision
CMT.
and CMT, yes.
So
What happened to CMT?
Sir, central macular thickness, there was no, sir, initially, sir, pre-op day and followed by day 1, there was increase in central macular thickness.
I think, okay, doesn't matter. Is there any relation of size of the capsulotomy with the complications?
Sir, size of capsulotomy.
If it is very large or very small?
Sir, actually I've compared the number of spots and the laser energy used, but
What was the cause for rise in IOP?
Sir, there is inflammation, prostaglandins and mediators, which was blocking the vitreous outflow, which caused
That means
increase in
inflammation.
IOP.
And why would you think that the vision kept on improving till day 30?
So ma'am, because the opacification we have cleared out, we have created an opening and cleared the visual axis.
No, at day 30, why did it go on improving?
Ma'am, there was improvement. Ma'am, there is settlement of inflammation also after the YAG gradually.
And also you could have excluded diabetic patients as well, because we all know that they are more prone to getting macular edema following any anterior segment procedure.
Yes.
So though in your study you didn't get any increase, but it would have been worthwhile to compare diabetics and non-diabetics.
Yes.
And actually you should have followed up these patients for more than 3 to 6 months to look for the incidence of retinal detachment. They have a very high incidence of retinal detachment, especially if you don't see the indirect outcome and the fundus with indirect outcome.
Yes, sir. Yes, sir, I'll keep that in mind. Thank you.
So, yes, please. We just wanted one picture, please, if somebody could take one picture for us. And while the photographs are being taken, thank you very much. We're finishing this session now.
Total.